I'm Bruce Marshall with the Cystic Fibrosis Foundation. I'm sorry I can't be with you in Istanbul. I hope you're having a great meeting and a great time in that fabulous city. The organizers of the conference asked me to give a presentation about quality improvement and specifically about how to launch and execute a quality improvement project, and that will be the focus of my presentation. We published the results of our efforts in the United States in the BMJ Quality and Safety Journal several years ago, and all these articles in this supplement are open access. You can find them at this link that I've provided. One of the articles in this supplement talked about the critical success factors, and there were 5 of them. First, the development of a strategic plan, or what we called an opportunity statement, the commitment of the foundation to implementing that plan, the investment in building improvement capacity at CF care centers, a focus on engaging people and families with CF, and the integration of quality improvement into our CF care framework. This is another resource that may be helpful to you. It's the 2nd edition of the Action Guide. You can find it at this website, the Clinical Microsystem website. And the title here says, we believe that the life expectancy of people with CF can be extended through the consistent implementation of evidence-based clinical care and practice improvement. There's a background section in this action guide that points out the importance of leadership, creating conditions for success, partnerships in care between people and families with CF and the healthcare professionals on the care team, the microsystems approach to quality improvement, and the chronic care model. I won't go through each of these in detail, but talk just a bit about the microsystems approach and the chronic care model. This is a wordy slide, but it's an important concept to get across, that a clinical microsystem is the combination of a small team of people who work together to provide care and the individuals who receive that care. It has clinical and business aims, linked processes, a shared information environment, and it produces services and care which can be measured as performance outcomes. This diagram shows how microsystems fit in that bottom image. One of those black rectangles could be a CF outpatient clinic. They roll up into a mesosystem, a pulmonary medicine or a chest medicine service, and that rolls up into the macrosystem or the healthcare institution. Microsystems are the key leverage points for transforming care. It's where quality and safety are made or not. It's where cost and waste are made or not. And it's where patient and job satisfaction are made. Just a brief word about the chronic care model. It was developed by Ed Wagner and colleagues in the northwest of the US, and it lays out the various ways that chronic care can and should be delivered and improved. And I won't go through all the details, but just mention that 3 of the powerful change ideas that Ed Wagner talks about is self-management support, helping patients and families figure out how to get the therapies in at home and manage their disease with respect to embedding it within their daily lives. Team care, which of course in CF we have. And then the other point that he makes is pre-visit planning. And I've circled where the action takes place when you bring informed, activated patient together with a prepared, proactive practice team for productive interactions. And again, Ed Wagner points out the powerful change idea of pre-visit planning. So now on to the main point of this presentation, how to launch and execute a quality improvement project. The action guide lays out 5 steps. Form a lead improvement team, complete an assessment of the microsystem, pinpoint focus areas, set goals, prioritize and test interventions, and then finally sustaining improvement. Step 1 is very important, and it's form a lead improvement team from the entire microsystem team. Here you can see all the healthcare professionals, and there are also a couple of parents in here, an important member of the team. An important resource that I've shown here is the team handbook. I'd encourage you to look at this. Not only talks about how to bring a team together, but also talks about quality improvement. There's a third edition. It's a little bit dated, but it's still great materials in this handbook. I'd encourage you to seek this out. One of the things that we've learned in the learning and leadership collaboratives that we've organized and run is that the basics are very important. Bringing a team together, forming that lead improvement team, and teaching them how to work together effectively as a team. And one of the fundamental processes is conducting meetings. And to conduct effective meetings, you need meeting roles, a leader who moves the group through an agenda, a facilitator that ensures everyone participates and follows the ground rules, a timekeeper to make sure the team stays on time, and a recorder to record the action items. It's important to use a timed agenda. This provides focus and efficiency. Use the end of the meeting to set the next agenda, and the meeting roles at that agenda ensures preparation for the next meeting. And sometimes it's helpful to actually evaluate the meeting at the end, what worked and what can be improved. The second step in the process after forming an improvement team is to complete an assessment. This is called the 5 Ps. And this is what Akron Children's came up with for their 5 Ps. It goes over the purpose, the patients, the healthcare professionals, the processes, and the patterns. And I won't go through all these 5 Ps. They're laid out very nicely in that action guide, but I'll mention just a couple. The first is the purpose. And John Canfield said about purpose, it's very important to clarify your purpose. What is the why behind everything that you do? When we know this in life or in design, it's very empowering and the path becomes clear. This may seem silly to think about your purpose, but ask yourself this question. Have you ever discussed this with your interdisciplinary team, why your program exists? Clarifying the purpose of your program so that everyone understands and supports can be a great team building exercise. Another P that I'll talk a little bit about is your processes. Know your processes. This is a definition of a process. Sequence of linked steps which consume resources, for example, staff time or money, to convert inputs, for example, a defect or a problem, into outputs. These outputs then serve as inputs for the next stage until a goal or end result is reached. Here's an example of a process. You want to do some reading at night and the lamp doesn't work. You ask, is the lamp plugged in? If not, you plug in the lamp. If it is plugged in and the lamp still doesn't work, maybe the bulb is burned out. You replace the bulb and you can get to your reading. If not, you're going to repair that lamp. Simple process. The same is true in healthcare. We have more complex processes, and this is just a starting point. You might start where it says assess. You do a complete assessment on a patient. You decide what needs treatment, and then you follow up. If that problem has been resolved, it loops back to maintain and prevent until you assess them on the next visit. You can build out this process in more detail, again, starting with that red triangle, rectangle in the middle, assessment. A patient comes to see you, and you decide they're sick for some reason, and you decide, do they have a pulmonary exacerbation? Is it mild or moderate to severe? You treat that and then follow up. If they're well, it goes back to maintain and prevent, and you reassess at the next visit. Again, this is a very simple process map. You can go into obviously much more detail. But process maps or flow charts Most of these are running in our heads. We don't have these well documented in healthcare, and that's a problem in and of itself. When you do a process map, then the whole team shares that model. It promotes standardization and in and of itself may identify improvement opportunities to streamline the process. It also can be a framework for potential interventions. And I'll illustrate that on that process map that I showed earlier. For maintain and prevent, you could do an intervention to make sure that the team has that patient on all the right chronic medications. At the assessment stage, you could standardize your team's definition of an exacerbation. For treatment, you could optimize the treatment by making sure you have the antibiotic doses right. And then for follow-up, you can ensure that every patient that has an exacerbation is followed through to resolution. The next step is to pinpoint the focus areas. And I'll use Akron Children's as an example. They went through their full assessment and they found out that through a survey that access to the healthcare team was a problem. They did a process mapping and that confirmed the problem. It was a messy process. So their focus area was to try to improve phone access, which was difficult for their patients in CF team. They also looked at their CF Foundation registry data and looked at the outcomes and variability, and they found the median FEV1% predicted for their children and adolescents was below average. And they found that surveying their care team, there was a lack of standardization in the definition of exacerbation. The next step in this 5-step process is to set goals, prioritize, and test interventions. And you want to set clear and specific goals, sometimes referred to as SMART goals. Use tools to help understand causal pathways. You can either use fishbone diagrams or driver diagrams, and I'll go over a fishbone diagram in just a minute. And then go on to develop and prioritize and test interventions through small, rapid, well-planned tests of change. Again, reflecting back to the Akron example that I showed earlier, this is how they moved on to goals and interventions for the patient access issue. They went on to streamline their phone system, and this was a win for patients, families, and the care team. In terms of the registry outcomes identifying the median FEV1 is below standard, they implemented a pulmonary exacerbation score to standardize their approach. Okay, this is called an Ishikawa diagram developed by Dr. Ishikawa, but it's commonly referred to as a fishbone diagram. And you can see the desired result all the way to the right, and then the primary drivers, the big arrows feeding into the main arrow, and then the secondary drivers, the sort of the fish bones that if you fill this out, it actually looks like the skeleton of a fish. So here's an actual fishbone diagram developed by a CF care team, and they were focused on trying to optimize nutrition. And you can see the major priorities that they identified: psychosocial, illness and comorbidities, funding, communication, patients, and healthcare system. And they went through a brainstorming exercise and filled in all of those secondary drivers. The key is to be comprehensive, but ultimately, as a team, you have to prioritize. What do you think are the high leverage points that if you can change or tweak the way you handle those, you can make a difference in optimizing nutrition? This prioritizing is very, very important because as a team, you have limited time. You have to kind of hone in on the top priorities. And this leads us into what's been called the model for improvement. The 3 questions at the top of the PDSA cycle are very important. Confirming, what are we trying to accomplish? What's the aim of this work? How will we know that a change is an improvement? What are the measurements that are going to tell us if we're moving in the right direction? What changes can we make that will result in an improvement? These are the interventions, the priorities that you've identified. And this shows PDSA as equal pieces of the pie, but it doesn't really represent the truth. Planning should be probably half of that pie. The planning is very important. Edward Demings is what some refer to as the father of process improvement or quality improvement, and he focuses on measurement. You can't manage that which you don't measure. There are various ways to track your progress. One is by way of a run chart. On the y-axis, the measured value. On the x-axis, time-ordered observations, and a center line, a median or a mean. As you get more sophisticated, you move to what's called a control chart or a statistical process control chart. It has the measured value on the y-axis, time-ordered observations on the x-axis, the center line, and it adds confidence limits, and you calculate these. And this is a way of distinguishing random variation from special cause variation. And here's an example of a control chart. You can see FEV1 % predicted on the y-axis, on the x-axis, time in months. You can see the red line showing the median FEV1 % predicted. The dotted lines are the upper and lower confidence limits. And you can see this run of 8 successive points on the same side of the center line. And that indicates there is some special cause variation. And in this case, it was a team that was working on improving FEV1. And that's resulted in this improvement. The fifth and final step is sustaining the improvement that you make. It's important to continue to measure, to develop what's sometimes referred to as a playbook with a standardized process and who does what when, so that knowledge is not lost with staff turnover. And then some teams do periodic audits to ensure the process is still working smoothly. So there's an analogy between caring for patients versus improving microsystems. When you see patients in clinic, you do a full assessment. If it's a complex patient, there may be multiple diagnoses. You treat that patient. Typically, if it's a complex patient, focusing on the top priorities, and you involve the patient and family in the process, and then you follow up to see the results of your interventions. Improving microsystems, the analogy is you do a full assessment to identify the opportunities, you pinpoint the focus areas, you set goals and test interventions, again involving the care team and the patient and family in the process, and then you work towards sustaining that improvement. A few other factors that you might want to consider in your work is it's easy to become overwhelmed. Focus on one project and engage the entire team, including the patient and family that you've engaged. I listed that as a separate point. This is very important to bring that lived experience and that experience and perspective that they bring. Communicate, communicate, communicate between the lead team and your full team with institutional and department leaders. Let everybody know what you're up to. You might want to seek out institutional resources and support. If you have a QI department, you may be able to secure some coaching to get you started on the right path. When you're a little further down the line, you might seek out high performers around the country or throughout the world and try to learn from them. You might even make a benchmarking visit to actually study the way they do their processes. And then finally, it's important to meet regularly and develop the improvement habit. So where are we going with this work? It's all about really changing the culture, getting the work done, and improving the work. You all have the professional knowledge, the medical knowledge, the personal skills, the professional values and ethics. We want to add to that improvement knowledge, systems thinking, process mapping, understanding variation in measurement, and human psychology. And bringing those all together to improve diagnosis, treatment, and care, and follow up and improve processes and systems in healthcare, because we believe that will increase value for people with CF. So I appreciate your attention, and I thank you, and I'm happy to answer any questions by email at bmarshall@cff.org. Thank you all.